Welcome back. Welcome to what I would consider the most important lecture you would probably have in your entire life. That's not an exaggeration. I wish when I was a young medical student that one of my professors would have shared this information with me. I would have been a much better doctor, a better husband, father, friend had I learned this earlier. Trust me, I'm still learning how to be a better listener. So, this is entitled Listening and Diagnosis. By the way, if you have not yet completed the attendance quiz that was supposed to be completed last week, please do so before the end of the day. Failure to complete this requirement means that there is no evidence of your attending classes so far, my classes at least, and this information, your attendance or lack thereof, will be shared with administration tomorrow. Okay, let's begin the series. This series of lectures is actually based off of a course on communications and health that I had the privilege of developing and delivering at my last medical school in South Africa. It was titled in those days The Lost Art of Listening. Today it has been retitled Listening and Diagnosis. As usual, and you'll get used to this pattern, we will cover the following learning outcomes: define listening, explain how hearing is different from listening, describe the various levels of listening, explain the difference between kinesics, oculesics, and proxemics. Discuss cultural influences or the use of metaphors, talk about barriers to listening, and we will describe the features of active listening. Now, I deliberately did not turn on the sound on this. This has been a regular occurrence in the last couple of years, not only in America. People all over the world are fed up of being silent and want their voices to be heard. I want you to pay attention to the woman in the middle of this shot. Can you hear her saying, I can't breathe? I can't breathe. Now, this is not an indictment of your generation where we are more interested in hearing our voices and not listening to what other people are saying. In my generation, here is what I learned from two of my favorite philosophers in the 1960s, Simon and Garfunkel. There is a verse, I think it's the third verse in The Sound of Silence, where they say, I trust you, I'm not going to attempt to sing it. Uh, and in the naked light, I saw 10,000 people, maybe more. People talking without speaking, people hearing without listening, people writing songs that voices never shared, no one dare disturb the sound of silence. And in case you think it was a problem in my generation, this problem goes back way, way back in ancient times. Socrates, who lived in the 4th century before the birth of Christ, was noted to have said, because he didn't write anything, Plato, his student, was the one who wrote what Socrates taught him. So Socrates, through Plato's writing, said, Nature has given us 2 ears, 2 eyes, and but 1 tongue, to the end that we should listen and see more than we should speak. But this was not a problem confined to the ancient Greeks. Almost a century before the birth of Christ, so 500 years before Socrates made his statement, Solomon, writing in Proverbs 18 verse 13 says, "He who answers before listening, that is his folly and his shame," encouraging us to listen before we open our mouth and speak. Did you know that listening takes up more of your waking hours than any other activity? Did you know that 70% of our day is spent in communication, and out of that 70%, 9% is in writing, 16% is in reading, 30% is in talking, and a whopping 45% is spent in listening. And when I talk about listening, I'm not talking about hearing. Hearing is defined as the perception of vibrating sound, while listening is giving meaning to what is being said. So, my definition of listening is a combination of what we hear, what we understand about what we hear, what we remember about what we hear. Because often we are accused of not listening when in fact we heard, we understood, but it skipped getting into our memory banks. Listening is crucial to effective communication. It's a skill like any other skill that needs to be developed. Now, how is listening different from hearing? Hearing is passive, involuntary, automatic. Mom has been going on, "I told you, and I've told you before." You have the and all he's hearing is wah 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 blah 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 blah. He is shut off. He's not paying attention because he's heard the song and dance before. Listening, on the other hand, is active, it's voluntary, and it's deliberate. You have to make an effort to listen. And to back up this, let me share with you a couple of an experiment that was done many years. It was back in the 1960s. A cat is placed in a lab, and the cat's auditory nerve, cranial nerve 8, is linked to a screen, an oscilloscope, and there's a metronome that is ticking away. Tick, 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 tick. And if you guys don't know what a metronome is a mechanical instrument that white people use in order to keep them in rhythm. Black people have an inbuilt metronome. They are born jigging into time with the rhythm of their mother's heartbeat, etc. White kids need to learn how to dance in time. And I've seen this with my own 4 grandchildren. 2 are African, 2 are white, and it was obvious which one, if I just saw them dance, which one was born in Africa. Now, what happened next in this lab was that they linked area 41, which is the auditory cortex in the cat brain, to the same oscilloscope, and every time the metronome went tick, 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 it showed an uptick in the impulse being generated by the inner ear, transmitted to the brain via cranial nerve number 8. Similarly, every time it went tick, tick, area 41 was picking this up as an impulse, and the cat is, yeah, he hears this rhythm. He may even, if he is a musical cat, be nodding in this. Now, second part of the um, lab experiment. Introduce a mouse. The metronome is still clicking. The inner ear cells in the inner ear are still firing. Impulses are still being conducted along. cranial nerve 8 to the brainstem, but look what is happening in area 41 in the temporal lobe. Flatline. He no longer is listening to that sound because he's busy thinking, hmm, lunch. How am I having that? With a little Tabasco sauce? Maybe some Thousand Island dressing? Nah, I'm just going to have it on the rocks like this. Crunch, crunch, crunch. So, demonstrating that hearing is occurring, but listening is not occurring. There's an interesting word in the Chinese Mandarin language. The Mandarin word for listening is tung. I think I've pronounced this correctly, but I could be wrong. I'm not very good in Mandarin. I learned in my time in Beijing many years ago studying acupuncture how to say yes, how to say no, how to say hello, how to say goodbye, and how to ask, are you in any pain? Because I was learning where to place the needles in acupuncture in my acupuncture clinic in the Guangzhou hospital, and I needed to make sure I was not on a nerve causing pain. The word tongue in Mandarin is actually broken up into three separate kind of symbolic writing. This particular one has you can look at this. This is the ear with a long earlobe. So the ear is part of listening in the Chinese Mandarin word tongue. Look at that. That is the symbol for the eye. You can see the upper and lower eyelids. You can see the rim of the cornea. This here is the symbol for the king that rules over all of this. And this bottom symbol here is the symbol for the heart. I can see maybe 1.5 ventricles. I can see blood associated with the heart. And when you put the four symbols together, the composite word in Mandarin says when you listen with your ear, you pay attention with your eye, you're looking as if you're listening to the king, and you're listening with your heart. So there are four levels of listening that are embedded in this composite word. The four levels are level one, listening for the words you're hearing, listening for the words, that is listening with the ear. You could be listening for meaning, how I frown, how I open my eyes, how I gesture with my hands, looking for meaning. So you're using the eye to listen. Level three would be listening for feelings, feelings to do with the heart. And then the fourth is listening with your soul or to the innate. What's your innermost part of your being actually saying? Let's look at each of these four levels in a little more detail. Level one. Remember, I said to you I was going to look at patient agenda. And this is how you listen with your ears at level one. You're listening for the patient's agenda, but you're asking specific questions which will give you a little more information. You're using the mnemonic 5. First F for feelings, I for ideas, second F for function, and E for expectations. And I would talk about each of these using a personal story of my interaction with a patient to tell you how, if you were to listen to the patient, you would then be able to get to what they're actually worried about or concerned about, and or etc. So feelings. What about your illness worries you the most? This is a 19-year-old patient I saw in South Africa, one of my very first patients. I was teaching family medicine, so it was the duty of the final year medical student to take a history, do a physical examination, come and present. I confirm the findings in the history and the physical, and then talk about what's his differential, diagnosis, treatment, etc. And the student had said, I've done everything. I said, including the patient's um, agenda. Yeah, and I got absolutely nothing. It was a 19-year-old who was concerned about lumps in her neck, axilla, and groin. This was generalized lymphadenopathy. She was concerned about a strange rash in the palm of both hands. And then she had some flat top warts in her vulval region. And I had said to the student, what is the diagnosis? Expecting him to give me one for all of these problems. No, he gave me 5 differentials for the generalized lymphadenopathy, 5 differentials for the rash in her hands, 5 differentials for the strange genital lesions in her perineum. Couldn't put this together and come up with one diagnosis. So I said, "Come, let's go to your patient." So we went to where the patient was, and I confirmed, yes, she had all of these things. And I said, "Okay, now watch what I am doing, how I ask, how I respond to the patient's response." First question to do with the patient's agenda: what about your illness worries you the most? And she holds her head like that, hangs it down, and she says, "I am worried that I have a serious disease." Now, if I were to ask you, um, if you were worried about something and I was your doctor and I asked you, how would you respond to somebody asking you that question? Um, they'd probably ask you another question. And I like to put myself in that patient's shoes and ask myself that same question. So the question that I asked young Maria, what about your illness worries you the most? I turned that question internally and I said to myself, if I were a 19-year-old girl and I had these lumps in my armpit and this rash in my genitals and the strange lesions in my hand, what would I think? And take it from there. Put yourself in that situation. What would you think if you were this patient? What, what might you be afraid of? So her response was, I'm afraid that I have some serious disease. And all the time, she was not looking me straight in the eye. She held her head down like this, hand above in front of her eyes. And I said to her, is this something that you were ashamed to ask me about? And she mumbled yes. And I kind of knew where she was going with this. And I said to her, are you worried that you may have a disease that you caught from your boyfriend? And she looked up and said, yes. And I looked at the medical student and I said, this is how you respond. Was there any particular disease that is spread by sex with your boyfriend that you could be worried about? She hung her head again down and said no. And then I said to her, are you worried specifically about syphilis? She says, maybe. Didn't raise her head up. And this was the early days of the HIV epidemic in South Africa. This is 1989. And at that time, in my other assignments with the U.S. government in other parts of Africa, I had seen hundreds of patients with HIV. This was my first, that it was going to turn out to be my first in South Africa. And I said specifically, are you worried about AIDS? She looked at me and said, yes. I said, good. Now we're getting to the bottom of this. I said to her, from the presentation, the three symptoms or signs you have, complaints, it is most likely that it's a secondary syphilis. And then she looked at me as if to say, and I said, but I don't know whether you have AIDS or the virus that causes AIDS. So do I have your permission to test your blood for syphilis and for HIV infection? And the answer was yes. And we did that, and she came back a week later, and she was horrified to learn that not only had she contracted syphilis, secondary syphilis, her VDRL was positive, her FTA-ABS test conformity test was positive, but her Western blot test was positive for HIV infection. And what upset her most of all was that there were posters that were plastered around the country that talked about the ABCDs or ABCs of AIDS prevention, abstention, be faithful, and if you can't abstain and not be faithful, then the C is use a condom. And it was her only boyfriend. She was faithful. They weren't abstaining. They were having conjugal sex. He was using a condom and still got the virus. And I think what must have been more upsetting was that knowing that her boyfriend was not faithful to her because he would have gotten this from somebody else. And we were able to deal with that from knowing what she is worried about. Next is the I. The I here stands for ideas. What do you think is the cause of your illness? So let me tell you about another story. This is a 24-year-old medical student, 23-year-old actually, complaining of low back pain. And when I asked him, what were you worried about? He was worried about something really wrong with his body. Okay. What do you think is the cause of your problem? He said to me, my back pain could be caused by dirty blood. Now, I grew up in a developing country background. I was familiar with the cultural term dirty blood. I'm not too sure if you're familiar about that in the United States, but dirty blood in the West Indies and in East Africa, Central Africa, and Southern Africa, dirty blood is a euphemism for asexually transmitted disease. So I said to him, I hear that. Why do you think, or how do you think your blood got dirty? So let me give you some background information. I saw him 2 weeks prior to asking him this question. He had come complaining of low back pain, and I thought young male, low back pain in the lumbosacral region, possible early ankylosing spondylitis. Not a bad hypothesis. So I sent him off for an HLA-B27. I sent him off an ESR, C-reactive protein. I ordered also rheumatoid factor, ANA, anti-double-stranded. I did the arthritis panel, which you will learn about next week, and I took an X-ray. Everything came back absolutely normal. So when he came back a week later for the reports of his blood test and everything was normal, I then backtracked and forgot that in my initial consultation, I did not ask him about his agenda. So we went through the agenda, got to the point of dirty blood, and I said, how do you think your blood got dirty? Well, this pain started 6 months ago. I had seen his girlfriend, and I'm going, I don't know who your girlfriend is. He said to me, I saw his girlfriend. He mentioned the name. It didn't make any difference. I still don't remember her. However, my diagnosis was that she had trichomonas. She had a green frothy discharge with slight malodor. I had examined the discharge under the microscope in my office, saw the wriggling Trichomonas vaginalis to confirm the diagnosis, came back to the office and said to her, you have Trichomonas vaginalis. Unfortunately for you, it causes this problem. Fortunately for your boyfriend who you got this from, he wouldn't know he has this problem because it's asymptomatic. I'm going to ask you to swallow these 10 tablets of metronidazole right now because I want to see you take it right now. It has a bitter taste. And then when she finished drinking, swallowing the tablets, I said, here's another 10 tablets for you to go home. Explain this to your boyfriend and have him take this in order to stop further reinfection. And apparently she went home and said, I saw the doc in the clinic. He told me I had something called trichomonas. He gave me some treatment and he said, I must give you these tablets to take this. Could you take this? And he says, sure, lovey, anything for you. Took the tablets and started to worry. If this is a sexually transmitted disease, and he was in his third year, so he had done pathology and microbiology before. If this is a sexually transmitted disease and I don't have any symptoms, you know where his mind is going. She has been unfaithful to me. And he's worried. He's been carrying this worry for the longest while. Every week he says to her, Lovey, am I still your only man? Am I your only love? Blah blah blah. And she keeps saying, yes, you're the, da da da. But he kept worrying about why does he not have symptoms. And now that I understood where he was coming from, had I asked him this in the first encounter a week ago, I would have saved the university and us time for the blood test and the x-ray. I would have saved him an exposure of x-ray to his body had I done this in the first consultation. So having known where he's coming from, then I could then explain to him why trichomonas is asymptomatic in the male, because the male does not have lining the urethra the particular ciliated columnar epithelial cells that are necessary for the growth of this organism. And he felt comfortable, and I said to him at the end of the consultation, oh, by the way, how is your back pain? And he stopped and thought about it, bent, touched his toes, twisted in every direction and go, wow, that backache is gone, doc. Thanks. Because I had addressed the cause of the backache, which happened to be a psychological concern rather than a physiological problem. The second F, functional effects. How is this illness affecting your daily life? I'm going to introduce you to Brian, a 45-year-old mechanic with low back pain. It's the first of a family that we're going to see every week for the next 14 weeks as we go through the rest of the course. Brian, 45-year-old mechanic, low back pain. He twisted his back 2 days ago. He's incapacitated and he comes to see me. And I'm going through functional effects. How is this affecting your life? And he looks at me and he says, well, I can't bend properly and I need a couple days sick leave. I said, yeah, I can give you 2 days, 3 days sick leave to recuperate. I'll give you some medication to help ease the pain while your body heals itself. Is there anything else that is bothering you? And he kind of looks down sheepishly, and I saw that he was looking not just down, but in the region of his groin. And I understood the body language, and I said, are you bothered about how this is going to affect you as a man? And he then looks me straight and he says, yes, doc, is this going to affect down there? And I said to him, no, because the most likely cause of this is a mechanical strain involving muscle or ligament. This is not a disc problem. Disc problems are likely to press on nerves of the spinal cord, and then is when you're going to get problems with that region. Back pain caused by mechanical issues to do with the muscle, and the ligaments don't cause that. And it was like, oh, thank goodness, because he had a young wife. They had 3 children. Maria was 38 years, and therefore he was concerned about his performance in bed, which I was able to address. And then the last is expectations. What specifically would you like me to do for you today? This was a 25-year-old male nurse who presented to me on a Monday morning with epistaxis. Actually, came in with a piece of tissue stuffed up the nose. He had had one episode of epistaxis over the weekend. It was in the middle of winter, so I'm thinking dry nasal passages. He might have picked at some dried stuff in his nose, scratched his nasal septum, bled a little. What What about your illness worries you the most? That this might be something more serious. I said, okay. What do you think is the cause of your illness? And I don't know. No problem. Sometimes we actually don't know, or we might know and are afraid to talk about this. How is this illness affecting your daily life? Apart from being inconvenient, no big thing. What would you like me to do for you today? And then he asks specifically, Doc, could you do me a WBC and diff? And I thought about this. So I'm going to order a complete blood count, which will give me, you'll learn this next week, hemoglobin, MCV, MCHC, a white blood cell count and differential platelets, etc. And I said, why specifically white blood cell count and a differential? And then the real concern came out. His younger brother, at 11 years, presented with acute lymphocytic leukemia. And guess what was the first presentation of his leukemia? Yep, it was nosebleed. And he was a nurse. He knows that maybe some of the leukemias are genetically inherited, and was asking, could this be the beginning of that condition? And therefore, I was able to, because normally you present with epistaxis. I look in the bottom part of your nasal septum, little area where most of your nosebleeds come from. I see an erosion there. I'm going to send you off to the ENT surgeon if I don't have a silver nitrate stick that I could touch the eroded area and cauterize this chemically. I would not be ordering a complete blood count, because you don't lose enough blood to cause an anemia. And leukemias is the last thing I'm thinking of in a 25-year-old healthy male nurse. So I was able to understand what he was concerned about. I was able to then extend my cursory examination from just the nasal passage to looking for lymphadenopathy in the cervical, axilla, groin areas. I looked for splenomegaly, looked for hepatomegaly. Didn't find any of those things. Checked him clinically for anemia. His mucous membranes were pink. There was no koilonychia. And then sent him off for a CBC, which would include the white blood cell count and differential. And he was able to return the day later with results that showed absolutely normal, and I was able to address his concerns. Okay, and this is how I'm just listening for the words. I may have been looking at their body language, but we'll talk about that later. I'm just listening for their verbal response. Any questions? Now, there's a difference between verbal response and extraverbal communication. Extraverbal communication. So, verbal is just the words. I am happy. I am here. I am going to school at Palmer Chiropractic. Straight words, I get information, but that's it. Extraverbal is listening for the tone and the inflection of the voice. I could have said extraverbal is listening for the tone and inflection of the voice, but I did not say that. I said extraverbal is listening for the tone and the inflection of the voice. For example, you're in a meeting and your colleague says, "That's a great idea." The words literally mean it's a great idea. Now, I could have said this with enthusiasm, with an upward intonation, like, "That's a great idea." And you will take away from "that's a great idea" that I really mean this. I could have said flatly, with a long pause, "That's a great idea." No change in tone, no up or down inflection in my voice. And you're going to think, you really don't like my idea. Or I could have said this in a slow, exaggerated drawl. "That's a great idea." And no, that is not a great idea. That stinks. That's a horrible thought. So when someone says that's a great idea, that sounds like a funeral march, believe the tone, not the text. Now that is all listening at level one, listening for the words and the tone and the inflection in which the words are said. You would hear your teachers do the same. I could be talking about a particular point on the slide and I could say, "Pay attention to this." And you go, "Okay." Some of you might not have heard that. But if I were to say, "Pay attention to this," most of you at that point would be marking a big fat red X next to that particular bullet because I have emphasized. You see what I'm doing right now? I am emphasizing, and I'm pausing deliberately. I am emphasizing that particular point, letting you know this is very important. Hint, hint. It may be coming on the exam. And for those of you who opt not to be present in a lecture, are missing these very important cues that we will give out to our students to help them to be better prepared for the upcoming test. Listening at level 2 involves body language. Here's a question I have for you. How much of our daily communication is nonverbal, not verbal or extraverbal? Nonverbal. Is it less than 20%? Is it between 20 and 40%? Is it between 40 and 60%? Or is it more than 60%? And I could ask by a show of hands, how many here think it's A? Good. How many think it's B, between 20 and 40%? Good. How many think it's C, between 40 and 60%? Good. And how many think it's more than 60%? Good. Now, if you were listening to me carefully, I was deliberately trying not to give any hints. My good was good in all four of the goods. It was good, 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 good. I did not stress or raise my voice at C from A, good, B, good, C, good, and then D, good. Because at that stage, if you hadn't made up your mind, you would have gone back and put C as the possible correct answer. Now, let's play a simple game of Simon Says. Do you guys in your generation know Simon Says? If not, humor me. Pretend I am Simon. I'm going to give you a very specific instruction. And that specific instruction is like this. I want you to do exactly as I tell you. Let me repeat this because this is important for you to hear and understand and remember. I want you to do exactly as I tell you. Obey my instructions exactly. Here are the instructions. Take the index finger of your right hand, touch your chin like this, and keep your finger right there on your chin. Now stop, don't move. Simon says stop. Without taking your finger off of your face, look at the person on your right and look on the person. No, don't move. How many of you actually have your index finger on your right cheek rather than on your chin as my instruction says? Now, this is an important lesson here. And what is the lesson? People are more likely to do what they see you do rather than do what you tell them to do. And that's a lesson to learn in life. If you want somebody to do what you want them to do, show them what you want them to do, not just tell them what you want to do. Okay, so listening to the nonverbal. What percentage of our communication is nonverbal? And the answer is, and this would be the answer to the question I asked you recently, it's 55%, and 55% falls somewhere in between C choice, which was between 40 and 60. 55% of our nonverbal of our communication is nonverbal in nature. There's a rule that most of you or some of you might be familiar with if you did communications as part of your undergrad education. It's called the 738-55 rule. This was accredited to a particular psychologist by the name of Meherbian, who wrote a paper in 1972. Albert Meherbian, UCLA psychologist, started a study in 1967, published in 1972, Relative Importance of Verbal and Nonverbal Cues in Communication, with reference to conveying feelings and attitudes. That was the title. What he found out, that 7% of the communication was verbal, 38% is extraverbal, and 55% nonverbal. The public got hold of this rule and publicized this, and it became a universal rule that went for years until it was challenged 30 years later. The 738-55 rule. That, in fact, is an urban legend. AMSL in 2019, and here's the link, did a study on this and commented on what the research that Malherbian actually did or began in 1967. He determined that the weight listeners placed on each of these elements, verbal, vocal, and nonverbal, had to do with expressions when asked to discuss their feelings. This 738-55 rule conclusion was based on a misinterpretation of his research. Nobody, apart from AMSEL challenging this, has gone on to look at what's the exact percentage. This is the only study. We know it's not right, but because it's been said so often, and if you continue, you know this from life, if you continue to say a mistruth, after a while, you will believe it's the truth, and others will follow your belief and then start to fight your battles for you in thinking whatever misinformation you want to generate out there. Any questions? If not, let's delve into listening to the nonverbal in a number of ways. It's also known by a fancy body linguistic term as kinesics. Kinesics is the study of the use of gestures, expressions, body posture, and the use of space in human communication. This study field of kinesics was started by Ray Birdwhistell, an American anthropologist who lived last century, died in 1994. He found out that we can communicate non-verbally by using gestures, and the gestures often are with the hands, but not confined to the hands. Let's look at some of these gestures. In America and in Canada and the UK, this means A-OK, everything is fine. Do you know that if you were to do this in France to a driver on the road that you are sharing, this means zero or you are worthless? You fill in the blanks. In Rio de Janeiro, Brazil, this is the equivalent of the middle finger. Ooh. In the Middle East, this is a rude sign referring to you're a homosexual. So much of what you're going to learn is needed to be taken into context. Don't believe that everybody understands what the AOK sign in America means. This one is almost universal. I don't know what triggered the former president George Bush to give somebody the middle finger. Do you know the origin of this gesture? The middle finger in ancient Rome was called by its Latin name digitus impudis. This was the digit, the finger that was used to clean your impudent area. It's called the pudendum. This was the finger that you used in the absence of toilet paper. Toilet paper was not invented back then. It was only invented a couple centuries recently. And you cleaned your anal region with your left middle finger. As I said, fun fact. Toilet paper was first invented by the Chinese in the 6th century AD and only mass-produced in the 14th century for use by the imperial court in China. Toilet paper was introduced in the United States in 1857, produced by Joseph Gaiety, and then mass-produced later on rolls in 1890 by Scott Paper Factory. Interesting fact, but we can dump that wherever we want to dump used information. This is the equivalent of the middle finger in Russia and the former Soviet territories. And if I were to see President Volodymyr Zelensky doing that during his interview with the president and the vice president, I would have said, yep, he is giving them the middle finger and they don't realize this. If you look at this carefully, pretend that this is an intimate part of the female anatomy, you will get what I mean. Sometimes the gestures are uninterpretable. This particular photo was captured during the second presidential debate in 2008 and is subject to various interpretations. In situations like this, the context is of utmost importance to find out what is being said, if anything. It was the moment where the debate had just been concluded. McCain had attempted to shake the hands of the moderator, Bob Schaefer. Schaefer moved to the opposite direction, leading to a brief awkward moment. Realizing that Schaefer was not there, McCain turned around, displayed a bit of humor with an exaggerated, I'm mixed up, I'm confused, I don't know where I'm going or coming, sticking out his tongue before reversing directions. And the public on the internet went off on a tangent as to what does this actually meaning. I mean, at the time, there was a viral meme known as Zombie McCain, like if he was a living dead. It was parodied, no context was given, no explanation, with various interpretations, and it was not, in my humble opinion, not intended as an insult or directed in any way to then candidate Obama. It was a spontaneous, self deprecating reaction to a minor onstage mishap, causing confusion, but showcasing John McCain's sense of humor. So you need to understand the context in which these gestures are being made. Here's the thumbs down. In an emoji, this means bad. I don't like this. This is come, or you want a piece of this, depending on what the rest of your body is saying. If your face is scowling and you're doing this, you want a piece of this scumbag, that's what it could mean. Um, this is an important point. So I'm going to raise my index finger to indicate how important this is. Who? Me? Are you asking me the question, Doc? And here's an interesting phenomenon I've seen worldwide. It's not only here. I've taught students in 4 continents around the world in the 50 plus years I've been teaching. You look at a person in the class, you may indicate with a finger, yes, you. And so if I were to point at John here, John is doing it right now. He is going me, and he's looking around to the person on his right and on the left. They're looking both at him to go, yeah, he's asking you specifically, John, not me, but you. I don't know why students do that, but as I said, it's a almost universal. And the last is, often I get this response, what is the cause of this? Surely you remember this from trimester 2. Doc, do you know that trimester 2 was 2 centuries ago? And all of that information I dumped off in boards part 1. We now have boards part 2. Therefore, the response is, I don't know. Or, who cares? You can also, by the use of the positioning of your body, send a message. This is all part of the kinesics. This diagram is self-explanatory. If we start from the left, go to the right, uh, she has her hand partially covering her mouth, um, implying don't trust any words that come out from this because I may be not telling you the truth. One of her arms is across her chest, so she is not open to communication. The young man, legs spread apart, looking over his dark shades, um, might be hiding something or might be menacing in nature. The guy in the middle has a hostile position, but he might be insecure. Crossing his arms in front of his lower abdomen might be suggesting he's closed minded or protecting his manhood. The young lady is losing interest. She may have something to hide because her hands are behind her back and her legs are crossed, saying that she's close to communication. And the one is asking by his body language, I think you're stupid, but I'm not going to say anything about that. Other body positions could indicate several things. So, standing with the legs together is a conservative stance that, according to Goleman, the source of this material, denotes deference. This particular one, standing with the legs apart, feet and leg shoulder width apart, signals dominance, determination, and asserting that your side of the argument is the right one. You're standing your ground. Shifting your weight from side to side or from back to front. The way your body moves reflects your attitude, Gorman says. Constantly transferring your weight from one foot to the other, rocking forward and backwards, is a comforting movement that indicates you're anxious or upset. Basically, this is a physical representation of what is going on in your head. You're between and betwixt many unsettling doubts and can't stop moving from one thought to another. Crossing your arms. Do not be too quick to jump to conclusion. This pose doesn't necessarily always means anger, but when coupled with crossed legs, it's a defensive position. Take note of the surroundings. More often than not, the stance may mean that the person is just cold or simply people are finding it comfortable. The way you walk speaks volumes about how others see you. Fast strutters come across as productive, competent, looking as if they are doing something important. They have a bounce in their step, perceived as upbeat personalities, and for a purposeful stride, walk from heel to toe. Interestingly, as an aside, most men land on their heels and most women land mid arches. Your hands and what you do with your hands also speaks volumes. Spreading your hands out as if serving somebody a treat off a tray might indicate you're open to new ideas being offered. If your palms were facing down or you clenched your fist, shows that you have a strong position, and you might not be so flexible. Flailing your arms does not mean you are out of control. Research actually shows those who gesture when they speak seem more energetic, more agreeable, and warm. As the people who gesticulate less, they are seen logical and analytical. Keep in mind that moderation is the key. Overly animated gestures border on being frantic, as if you are appearing to be unbelievable or less power. Pointing your toes also confirms or sends certain messages. If your toes point in, even if you are sitting or standing in a straight position with your shoulders aligned and your head up, all signs of open body posture, your feet might be betraying you. If they're cocked inwards, big toe to big toe, this may indicate you are beginning to close yourself off because you're feeling awkward or insecure. Tapping your heels, sliding your feet in and out of your shoes, bopping your foot up and down while crossing your legs, the more uncomfortable you are. This is because these kinds of movements are actually tension relieving movements. Fidgeting may also mean that you want to be out of the situation and your body is ready to take flight. Bottom line, at least in professional settings, cross your ankles to calm these fidgety feet. Any questions? Now we're going to take a look, pun intended, to oculesics. What is oculesics? This is the study of eye movement behavior and communications, especially how people use their eyes to express emotions, convey messages, or interact socially. Again, Birdwhistle is responsible for developing this field within the broader field of kinesics. The intensity, duration, or avoidance of eye contact may signal the following: confidence, interest, dominance, but in the case of avoidance would be discomfort. Excessive blinking might indicate nervousness. Infrequent blinking could signify that you're trying to focus or stay concentrated on what the person is saying. I'm going to show you two pictures. You may or may not have seen this in classes in Psychology 101. This was the first time I saw this many years ago. The professor showed us two pictures and asked the question, who is prettier? The girl in picture A or the girl in picture B? Research that has been done for many years shows that when you look at them side to side, people think the girl in B is a lot prettier. It's the same person, but there's a subtle difference between the two. Can you spot the difference? Some of you can, some of you can't. Look carefully at the size of the pupil, the girl on the left side A and the girl on the right side. You will see that the girl on the right side's pupil is a lot larger. Often in the research that has been conducted, people, especially women with dilated pupils, appear to be prettier than they actually are. Pupillary dilatation could reflect interest, arousal, or fear. It's the same sympathetic nerve that is responsible for pupillary dilation. In addition to drugs like cocaine, amphetamine, MDMA, or atropine. The opposite, pupillary constriction, could be due to drugs like fentanyl, oxycodone, or barbiturates. I remember I was examining, part of a team of examiners, post-grad examination in psychiatry, looking to see whether the candidates had enough knowledge of neuroanatomy to apply to the field of psychiatry. And one of my, couple of my fellow examiners commented on a particular female resident that was being examined and said, "Wow, she's very pretty, isn't she?" And I looked at her and I said to them, "Not really. You are reacting to the dilated pupils that you are seeing. In fact, I would rather suspect that she is on some form of medication and didn't do anything about this. We had heard a rumor that this particular resident was sleeping with the head of the department in psychiatry, and 3 weeks later, she was found dead in her apartment from an overdose of amphetamines. I wish I had said something before, but I just have to live with that consequence. Speaking about drugs, atropine is a drug used to counter the effects of organophosphate poisoning. Atropine is a derivative of a plant known as Atropa belladonna or deadly nightshade. This is a muscarinic antagonist, and as I said, used to reverse the effects of organophosphate poisoning. It counters the poison's sympathetic overactivity, which is bradycardia, to the point where the heart would stop beating, and pupillary constriction. When I would use atropine to reverse these severe parasympathetic overactivity effects, my instruction to the nurse was give her enough atropine every 5 minutes to cause atropine toxicity. So patient's pulse rate had to climb, and then the pupils started to dilate, and then I would say stop. She is now completely covered. We just have to wait for both activities to resolve itself. But look at the name of this plant, Atropa, from which we get atropine. Does anybody know what belladonna means? Belladonna in Latin or Italian means pretty lady. Women of the European royal courts in the 16th and 17th century, in order to enhance their appearance and appear to be more beautiful, actually dropped tinctures of belladonna plant into their eyes to cause temporarily pupillary dilation, which will make them more appealing to their male counterparts. Another issue with gaze is the direction of the gaze. Where and how someone looks at you might indicate they're paying attention, they're interested in you, or like in this clip here from Abbott Elementary, he is avoiding answering the question by looking everywhere else besides you. But this again is culturally determined. Many of the cultures in southern Africa would say avoid direct contact with your elders. It was a sign of disrespect. If a younger person looked directly into the elderly person's eyes, it would be seen as disrespectful. In the white culture, it's the exact opposite, and this is where confusion came about when I worked in South Africa for almost 13 years. I was kind of a mediator between the two cultures. I was neither black nor white. I was, as you know, I'm brown skin. The white folk would say black people can't be trusted because they don't look you straight in the eye. Black people claim that white people can't be trusted because they are disrespectful to you by looking at your elders directly in the eye. And I'm going, whoa, guys, here is the cultural explanation or understanding for that. Any questions? The next group of kinesics is the field known as proxemics. Proxemics is the study of spatial distances between individuals in different cultures and situations. This book is a seminal text that was compulsory reading for those of us who were in some way involved in the diplomatic corps. And this was our reading prior to going out on an assignment in a foreign country. This was called The Silent Language by Edward Hall, another anthropologist. Edward Hall studied people's position, how they related to one another. He argues that much of human interaction is governed by what is culturally learned unconscious behavior, what he calls the silent aspect of our language. He explained in his book how different societies rely more and less on implicit nonverbal communication, and used this particular picture in his book to show four people. Can you infer by just their positions something about their relationships? There's a group of three that are in the foreground. They're standing close together, forming a small triangle. The man in the middle has his hands behind his back and his feet closed, signaling he's paying attention, but he has some form of formality or is being neutral. The woman on the left, this is according to Edward Hall, is oriented towards the group, holding a handbag, appearing to be engaged in the conversation, while the man at the right, on the right, is in a kind of defensive position, hands behind the back, suggesting curiosity, maybe listening or reserved engagement. Their close proximity and open body language or appearance orient towards them suggests that one, they know each other and they are more likely to be engaged in a conversation. The woman in the background to the right, she's physically distant from the group, turning away, holding a cup or an object in her hand. Her posture is closed off and she's facing away, suggesting she's not part of that conversation and possibly feels excluded, disengaged, or is intentionally trying to separate herself. The angle of her body and her separation suggests she does not share the same social bond with the group of three. This image is likely to be used to uh, demonstrate proxemics. Hall's theory was how people use space to communicate, um, is indicative of how far away are they standing or how close they are standing. In that close triangle, you can see that the woman and the man in the center are closer to each other, suggesting maybe a closer relationship than the man on the right. As a result of his studies in proxemics, Hall and others came away with four distances. The outermost ring in blue is the public distance, which is 3 meters plus, 9 plus 10 feet plus. This is the position most lecterns are placed at this distance to maintain that physical open space barrier between students and the teacher. The space in yellow is a little closer. This is the social distance between 1 to 3 meters. This is just the level of acquaintance. I'm just being polite. The green is the personal space between 0.5 to 1 meter in diameter. And then when you get close up in the red, where you are practically in somebody else's face, 12 to 15 inches, 30 centimeters. Again, this is the space for very close friends, wives, and husbands. But once again, this is culturally dictated by the different cultures. Hall talks about when he was on assignment in Buenos Aires, in Argentina. He had taken a silent movie of the people in the attending the cocktail party, and he says if you were to speed this up by about half the speed more, it was as if they were in some dance relationship. The Latin Americans, the Argentinians, they are up in your face like Italians, and they want to get close to you. And if you are from an Anglo-Saxon background, English or American diplomat, they're invading the green space. You may have a very large, intimate red space. You may think that they are invading your personal space. And what he saw happening was as the Latinas tried to get closer in the conversation, the Anglo-Saxon diplomats would back away. They will move to the side. The South American diplomats would move to the same side and move closer. They would back away, and as if they're doing some strange version of the Argentinian tango. Um, as I said, the Latin Americans he noticed had very small social distances, and their social distance is the equivalent of the personal distance in the English um, or American society. Does it really matter in practice where you sit or you stand? Here's an interesting study. And the study was done looking at the effect of sitting versus standing on the perception of provider time at the bedside. And this was done in the University of Illinois a couple of years ago and published uh, in the Journal of Patient Education and Counseling in 2012. In this particular prospective randomized control study involving 120 adults post-operatively that were admitted for elective spine surgery, the actual length of time between the interactions of the provider sitting or standing were compared to the patient's estimation of the time of their interaction. The researchers found that patients perceived that the provider that was present at their bedside sitting appeared to be sitting longer at the bedside as opposed to those that were standing, even though the actual time was not different. And it made a difference whether you were sitting or standing. Patients with whom the physician sat reported a more positive interaction and a better understanding of their condition. And the conclusion of the researchers was that simply sitting instead of standing at the patient's bedside or at the examination table or examination couch could have a significant positive impact on patient satisfaction, patient compliance, and provider-patient rapport, all which we know are factors that are going to play an inferential role in decreasing litigation, decreased lengths of stay, decreased costs, and in improved clinical outcomes. You might have to make a decision as a clinician. Where are you wanting to be in relationship to the patient when you are in the clinic? So that is something you need to bear in mind and decide on your own whether you want to be standing over the patient asking them questions, sitting at the same level on a chair as they are lying on the adjusting table, or in some other configuration. Any questions? Let's look at level 3 listening. Level 3 listening is listening with the heart, or empathetic listening, if you really want to feel the emotions being expressed by your patient. So let's look at some of the emotions that patients will communicate to you, sometimes verbally, sometimes non-verbally. Saint Jerome, a 4th century Catholic priest, theologian, and historian, said long time ago, the face is the mirror of the mind, and the eyes, without speaking, confess the secrets of the heart. How true. Did you know that you can look at the patient's face and eyes and tell what emotions they are experiencing? If not, you need to learn how to do this. And remember, I said all of these skills are learnable. So, what emotion can you tell me is being expressed here? And if you said joy, you would be absolutely correct. How about here? If you tell me that this is sadness, go to the head of the class. Well done. How about this? Note the furrowed eyebrows, note the clenching of the jaw muscles. Here is anger. What about this? Surprise! Hi, honey, I'm home early. You know what that means. Somebody's going to get lucky. No, maybe not. You might just have an early dinner. How about this? Eyes open, mouth open, head taken aback. That's fear. And this one is classic. In fact, we have a English idiomatic expression, looking down your nose explains that this is contempt. You're beneath me. I'm not going to be dealing with that comment because no, you're just beneath me. How about that one? Yeah, this usually is accompanied by who dealt that stinky? So this is disgust. How about this? This was this young girl's reaction when, at her birthday party, her parents got her what she'd been asking for the whole year, got her a pony. She's ecstatically overjoyed. She is over the moon because of this. But unfortunately, this young patient has a rather uncommon medical problem. Her problem is known as Moebius syndrome. Moebius syndrome is characterized by the congenital absence of facial nerve. She is expressionless. There is no facial nerve controlling muscles around her eye, muscles attached to her eyebrow, muscles attached to her nose or her mouth. She's just happy but can't show this with her expression. How about this one? Which person is really smiling, or which person is going through the motions of smiling, being polite, uh, implying, yes, I enjoy your joke, but actually has no interest in laughing at your joke because it's not funny. It's the one on the left, A. If you note the difference between A and B, is that there's no crinkling of the skin around the corners of the eyes in the patient in the picture A. Sorry, you can see the crinkling in A but not in B. Duchenne, this is called a Duchenne smile, the real smile in which the upper half of your face confirms you are enjoying the conversation or the joke. Um, Dr. Duchenne is the same Duchenne whose name is associated with Duchenne's muscular dystrophy. He spent a lot of time looking specifically at various muscles in the body. What emotion? So not only are emotions transferred transmitted via facial expressions. It could be translated via other gestures. The clenched, the broken piece of the pencil suggests relatively controlled anger. He actually wants to stab that person for whatever upset him. So this is anger. Sometimes we use the entire whole body to showcase how we are feeling. So, what is here? This is dejection. This is a sense of hopelessness. He probably got dumped, got fired, uh, came home and found that his wife has packed up and left him. And he's walking away ever so slowly, shoulders down, head down. If you were to look at his face, the corners of his mouth would be down, the corners of his eyes would be down, and he's just 2 seconds away from possibly bursting into tears. Any questions? Let's look at level 4 type of listening. This is listening with your gut. We have various names for this. I don't know what name you use. Some people talk about intuition. Sometimes we hear feminine intuition, implying that males don't have intuition, and that is not true. In chiropractic, we talk about the innate. In the New Age environment, we talk about spirit guides. In Christianity, some of us will talk about the Holy Spirit. And we all have stories in which we are doing something and out of the blue, a word, a thought comes to you. I remember um, having a third year medical student sent over from the hospital. I was still working in the Department of Family Medicine, and the clinic nurse had referred Andrew with a complaint of he hadn't slept for 3 days. He was hearing voices with a possible diagnosis of early schizophrenia. So I'm going through my history, because the diagnosis of schizophrenia is made on the history. You've done schizophrenia as a mental health issue. There are the 4 A's that are associated with the diagnosis of schizophrenia, and I'm checking the boxes off. There's loss of affect, there's auditory hallucinations. He has 3 out of the 4, so I'm thinking this might be early schizophrenia, might be what is known as hebephrenic schizophrenia, and I am in the process of writing a referral. And I'm speaking to Andrew, I'm saying, um, it's a pity that you can't hear what the voices are saying, because I needed to, this is me speaking, not to him, to determine is this paranoid schizophrenia, which has a worse prognosis than hebephrenic schizophrenia. And I said to him, I was sending him over to one of my colleagues. I didn't mention the word psychiatrist because I was concerned that, he might be turned off. I said, I have a friend who specializes in helping patients who hear voices. He either will listen to them and talk to them and help them to clarify what the voices are saying, or put them on some medication which will stop them hearing these voices speaking to them. I mean, Andrew knew that these voices were not speaking nice things. He described the voices as murmurs. If you were to go close to a group of your colleagues, and you hear them and looking at you, you're thinking that they are bad talking you. And in the middle of my explaining this to him and writing the referral note to my psychiatrist friend, I felt the Holy Spirit said to me, nope, Andrew's problem is not mental or physical or emotional. His problem is spiritual. You need to let him know that and to pray for him. And I'm debating with myself and the voice in my head. It would look very strange if I said to Andrew, you know what? I don't think your problem is schizophrenic. I think your problem is spiritual, and I need to pray for you. I continue to have this discussion. I'm sure Andrew is going to say to me, that's interesting, Doc. How did you get to know this? And if I said to him, well, God spoke to me, he's going to think, wait a minute, you're sending me to a psychiatrist because I'm hearing voices, but it's okay for you to hear voices and you're claiming this from God? Who is the one that actually needs to see the psychiatrist? Come on, Doc. And I'm debating whether to obey the Holy Spirit's prompting or not. So I eventually said to the Holy Spirit, if this is from you, let Andrew bring up the issue of God, Jesus Christ, religion, church, or whatever, and I will do what you have asked me to do. Okay, so I hear nothing. I put the letter in the envelope, give it to Andrew. Andrew gets up, goes to the door, says, thank you, Doc, opens the door, and before he leaves, he turns around and says, oh, by the way, Doc, and you're going to have many of these by the way pieces of conversation. Those are probably the most important pieces of information you are going to get in your consultation. The by the way, off the cuff remark. He says, by the way, doc, my mom thinks that my problem is I need to have Jesus in my life. And I'm going, oh dear. Okay, Andrew, come sit down there. Give me that letter. I tore the letter up and said to him what I thought the Holy Spirit was saying, that I'm not sending you off to the psychiatrist. I'm going to encourage you to go to your mother's pastor and have a talk about God and Jesus Christ and why you need Christ in your life. And I want to see you back in 2 weeks' time. And I prayed with him. I wanted to see him back in 2 weeks' time because I wanted to make sure that when he left, he didn't end up 2 weeks later in the psychiatric asylum because I missed early schizophrenia. And I could leave the story right there, but the story continues 3 years later. I eventually left the Department of Family Medicine. I went over to teach my favorite subject, which was not pathology at the time, it was anatomy. I was now an anatomy professor dealing with students, teaching medical students and dental students and physiotherapists and occupational therapy and nursing students anatomy. I loved it. And one day, 1 week in my life, 3 years later, I was undergoing a particular bad patch in my spiritual life. Our pastor at the church had asked a question: how many of us had actually led anybody to receive the Lord Jesus Christ as their Savior in the last 3 months? A couple of people put their hand up. In the last 6 months, in the last year, I never put my hand up no matter what time period. He offered because I never had the privilege of leading somebody to the Lord Jesus. I shared my testimony. I told him what God had done, how miraculously he touched my heart and called me into his family, but never had the privilege to say, let's go through the ABCs of salvation. A, acknowledge you're a sinner. B, believe that Jesus Christ died for you. C, confess all your sins and you will be delivered. D, into sharing eternal life with God. Never had the opportunity. So in the middle of that week, I'm being hammered by another voice. Yeah, I hear voices too. You're not the only one. So there's another voice in my head that says, call yourself a born-again Christian. You're just a bloody hypocrite like everybody else in the church. You haven't led anybody into salvation. You're not going to get through the gates of heaven. I'm going to welcome you into my gates of hell, where we're going to have fun for the rest of our lives. And I'm feeling like a piece of trash. Fast forward Wednesday morning, I am preparing for a class in general anatomy on upper limb anatomy, in particular the carpal tunnel area. And when there was a knock on the door, a young black man came in, said, "Good morning, Dr. LaRose. How are you?" I said, "I'm fine." And by obviously my body language, the way my face didn't express any recognition, I didn't recognize who he was. He says, "You don't know who I am." I said, "No, I'm sorry. Forgive me." He says, "I came to see you 3 years ago." Didn't make a dent in my memory. I was complaining of not sleeping for 3 days, and I said, "And you were hearing voices, and your name is Andrew." At which point his face lit up. He was glad that I remembered him. Unfortunately, I filed people's data in patient files in my hippocampus. So unless you give me a clue of a medical complaint, I have no clue who you were or are. And then he said, I said to him, Yeah. What happened to you? I mean, I no longer teach the third year. I am only teaching the second year. I'd seen him as a third year medical student. I said, "Have you finished your medical studies?" No. He says, "You and my mom were the only people who recognized what my problem truly was. I needed God in my life." And I spoke with her pastor and I became a born again Christian. The Holy Spirit led me to come out of medicine. I am a rural Pentecostal pastor. I've been preaching for the last 3 years out in Soshanguve or wherever, and God is moving. There are miracles. People are being saved, etc., etc. I'm going, wow, this is great. Um, why are you here particularly today? And he looked at me and he said, "You won't believe this." And then he thought about what he says. "No, you will believe this because you know this is how God operates." He says, "Doc, last night I had a dream. And in the dream, the Holy Spirit said to me, 'Go find Dr. LaRose. He's in the hospital,'" or he thought he heard hospital, "and let him know what happened to you." So he left early in the morning, took him 3 hours to come out from his village, catch a taxi, come to the hospital where I was attached. Went into the various departments in the hospital, couldn't find me. Somebody said to him, he's no longer working in the hospital. The last he heard, he was teaching anatomy in the university. So he came over the fence because it was just a plain 6 foot fence that separated the hospital from the university. Eventually found me, and he came to let me know that the words that I spoke, the prayer that I prayed 3 years ago, actually literally saved his life for eternity. So, yes, listen to your gut, listen to the innate, listen to the Holy Spirit or whoever is speaking to you. Now, sometimes these emotions could come across in the form of special words. And these special words are metaphors. You know what a metaphor is, it's a figure of speech. And these are metaphors that are specifically linked to illness. So I started the definition of a metaphor. A metaphor is a figure of speech in which a word or a phrase is applied to an object or an action suggesting resemblance or symbolic meaning. What does this picture, which is being used, what's the metaphor? You're calling somebody what? A couch potato. You're lazy. You sit there doing nothing. All you do is feed your face and you watch TV all day. So that couch potato is a metaphor. There are specific metaphors that are for anatomy. We talk about the roof of the floor of fourth ventricle. We talk about the floor of the inguinal canal. We talk about the 7 layers in the anterior abdominal wall. We talk about blood in a ruptured ectopic pregnancy running down the paracolic gutters to get underneath the diaphragm. We talk about the arches of the foot. We talk about the columns of Bertini in the anorectal junction. Similarly, in physiology, we have other metaphors. The metaphor here is a manufacturing plant. So we talk about the heart as a mechanical pump. The kidney and the ureter and the bladder are the waterworks of the body. We talk about the tubules in the kidney. We talk about electrical circuits in the heart. We talk about lubricating fluid in the joints. We talk about conduction of impulses along nerves. We talk about in the endocrine system, feedback mechanisms. All of these are metaphors in physiology. The metaphors in pathology are the attack war metaphors. You've had a heart attack. You've had a cerebrovascular accident, like a motor vehicle accident. The body mounts a defense mechanism against the attack. The intestines are obstructed. The bones are deformed. The blood vessels are obliterated. And this is all attack military metaphors. And then there's the metaphor of body armor. This was discovered by a German physician by the name of Wilhelm Reich, who trained under Freud and initially made some valuable contributions to the theory of psychoanalysis, particularly in the area of sexuality and character structure. While Freud emphasized the symbolic and unconscious aspect of neurosis, Reich focused more on the social and physical dimensions, in particular sexual repressions. He claimed to have discovered a universal life force that he called the orgone, that supposedly was a massless, omnipresent substance similar to the concepts of qi in traditional Chinese medicine and prana in Buddhism or Hinduism. He believed that orgone energy could influence health, emotions, and even the weather. He described this energy as both biological and cosmic, and in order to harness this energy, he built several boxes in the shape of a pyramid made up of alternating layers of organic and metallic material. The patients would sit inside for a half an hour, pay $50, which was a sizable amount back in the 1950s, to absorb the orgone for therapeutic benefits. He was actually kicked out of practice in a multidisciplinary practice in Vienna in the late 1930s, just before the war, came to the United States, continued to develop his orgone therapy and market the orgone boxes. Unfortunately, the concept lacked imperial support, even though he wrote Albert Einstein to get him to examine the circuitry and identify what kind of energy source are we talking about that he is manipulating, and was widely regarded by the scientists in America as a fraud. In the field of psychotherapy, he theorized the following: that psychological defenses are held in the body as chronic muscular tension. He called this the character armor or the body armor, and developed a therapy in which he encouraged physical manipulation by breathing exercises, massage, or some other form that would trigger an emotional release to dissolve this muscular armor and release the repressed emotions and built up energies. He marketed these orgone accumulators in the United States, ran afoul of the FDA, and in 1952 was charged by the FDA for peddling fraudulent material, because he was using this to cure not only mental illnesses but even cancer. The FDA in the 1950s investigated his claims and found that his orgone accumulating devices were fraudulent, medical equivalent equipment, and in 1954 they ordered him to stop distributing these accumulators and literature promoting them. He refused to comply, insisted that the court had no jurisdiction over science, and opted to defend himself. Now, he went against the equivalent of the original statement that I started off with, that a doctor who treats himself as has a patient as a fool, there's an equivalent in legal practice. The lawyer who defends himself has a fool for a client. Obviously, he failed to defend himself properly. He was found in contempt of the court and he was sentenced to 2 years in prison and unfortunately died from a heart attack and heart failure in 1957. However, his work has not been um, disregarded altogether. It has actually formed the basis of a couple of important alternative therapies, sexual liberation movements, and even the counterculture thinkers in the 1960s and 70s. And if you were to look up body energetics, etc., there's a whole new movement of body work therapies, including breathing exercises. But he found that particular emotions got stuck in particular places. And I'm going to discuss a particular disease shortly that we'll spend a little more time when we discuss fatigue in week 9 or 10 later on. This disease is known as fibromyalgia. For those of you with a physical therapy background, massage background, this is a disease that is associated with chronic aches and pains in 18 different sites in the body, associated with insomnia, fatigue, poor concentration. We're not too sure whether this is a psychological problem or if this is an organic problem, but that's not here or there right now. Back to Wilhelm Reich, the body armor theory that he developed led to a different understanding of the various tender points that are characteristic of fibromyalgia. Integral to the diagnosis of fibromyalgia is the need to find 11 out of these 18 tender, not trigger. There's a difference between a tender point and a trigger point. And these are 18 specific places in the body. Related at the back of the mastoid process, the side of the neck, second costochondral junction, upper trapezius, lateral epicondyle in at the elbow, the not infraspinatus, the rhomboid muscles attached to the medial border of the scapula at the back, the upper gluteal regions, inner upper quadrant, near the SI joint, the greater trochanter, and on the knee, the medial fat pad, not the lateral fat pad. These are 18 places that you're going to have to learn how to palpate and press with a fair amount of pressure, no more than 4 to 5 pounds of pressure, and you will learn how to do that later. But doing body work understanding, following the Rishian theory, I've come away with the following meaning of different tender points in the tender points that are related to the suboccipital region is stubbornness. Tender points that are related to the neck, the trapezius, the second costochondral junction, and the lateral epicondyle are related to anger that needs to be expressed outwards, but because of whatever circumstances prohibits that, the anger is turned inwards at the patient. Tenderness that is intrascapular in the region of the rhomboid muscle is fair. Tenderness over the SI joint and the greater trochanter to do with psychosexual issues, and tenderness over the medial fat pad in the knee has to do with reluctance to move forward in the future either a move in the job, a move in a relationship, or some move. And to illustrate this particular point, what I also found was that patients who had problems on one side, it might indicate the sex of the person you're having a problem with. So left-sided issues usually suggest that the conflict may involve the opposite sex. So if a male had many of his tender points, not trigger points, on the left side, he was having a problem with a female. If a female had problems on the right side, she was having a problem with the same sex. I'm going to share one particular story to illustrate this application. I was once treating a patient with chronic headache who had had headaches for the past 3 years. And in part of my examination at that stage of my life, I would look for the 9 pairs of tender points. She knew it was tension. She was a medical student. It was classic tension headache, tension type headache, meeting the IHS criteria. And I said to her, I would want to explore what is the cause of the tension, and she wasn't aware of any particular tension she was undergoing at that stage. So I said, let me examine you. And she had tender points in the following area. On the left, suboccipital, trapezius, lateral humeral epicondyle, left second costochondral joint, left SI joint, left greater trochanter, and left medial fat pad. Trying to put all of this together, I said to her, here is what I think your body is trying to tell me. So this is body language beyond body language 101. This is like body language 202 or 303. Advanced interpretation of body language, looking at the body armoring theory. And you could try this on your friends. And then as you get more comfortable, you might be able to help your patient. So I say, this is what I think. This is not what your body's saying. This is what I think. I could be wrong. Um, you have been in a situation with a man a little more than 3 years, because remember, she was having these tension headaches starting 3 years ago, that put you in a situation where you were forced to do something you didn't want to, so you were being stubborn. And this had to do with the suboccipital tender points. It left you feeling angry, where she had residual tension in the lateral humeral epicondyle, in her trapezius muscle, and in the second costochondral joint. And because she had this one spot over or in her rhomboid muscle, I said there is a sense of fear involved in this, and it involves a possible psychosexual event, and has left you feeling undecided what to do in the future about relationships. Upon hearing my explanation of what I thought her body was saying, she burst into tears. And after much crying and tons of tissues, I keep boxes of tissues in my office, she was able to share that 3.5 years ago she was going home from a late lecture in chemistry from the university. Somebody offered her a lift home. He raped her on the way and then dropped her off at home. And when she attempted to explain to her husband what transpired, his response was, what do you expect if you're going to dress like a slut? She never talked about this again until that afternoon in my office. And lo and behold, at the end of the consultation, at the end of the crying and sharing of the story, guess what happened to her headaches? Disappeared completely after sharing what happened with me. You may think that's amazing. You can have that kind of practice where you go deeper beyond the subluxation at C6, subluxation at T4 or subluxation at L2, looking to see if there's any underlying emotional issues, as Murphy talked about, to do with fear, to do with catastrophizing, to do with depression or passive coping. You're going to see these patients in your office, and if you remember the story, you might be able to help these patients to heal if you can read their body language at this deeper level. Any questions? All right, so let's talk a little bit about another aspect of communications and listening. Sometimes people don't want to share their story and they need a little encouragement. And I found a very good book that is available on Amazon. It's called The Anxious Patient, The Therapeutic Dialogue in Clinical Practice, written by two Swedish psychiatrists, Bendix and Wright. And in there they offer a number of, it's a very small book, 70 pages, published by Churchill Livingstone in 1982. They give very succinct bits of advice like repeat the last word the patient says. And I know this sounds, problematic. The patient is going to think, why are you parroting me? But try this out on a conversation with a friend who doesn't want to tell you exactly what is going on. You say, are you okay? Yeah. And you go, yeah. Well, not all that right. And you go, not all that right. They take a deep breath. You take a deep breath. And trust me, they will not be seeing any of this. This is your way of connecting with them. We're going to talk about this later. It's kind of mirroring some of their body language. And mirroring their body language is like them looking at themselves in a mirror. And most people, there's only one person I've encountered in my life when I said, two actually now that I think about this, do you really like yourself? And the response was no. And that led to a much deeper discussion. So the first thing is repeat the last word your patient says. The second is after they've given you some information, is paraphrase what they have said. And you go, okay, let me see if I get this correctly. You've had this backache for 3.5 years, and you're looking at their facial expression. You're looking at the nodding of their head, and if it was 3.5 years, they will be nodding their head. If you mistakenly said it was 4 years, they will go, no, 3.5 years. You go, I'm sorry. I miswrote that. 3.5 years ago, it started when you did this. This is what makes it better. This is what makes it worse. You were concerned about this, and at the end of your using your own words to tell them what you just hear, that will encourage them to talk because you are in the process of demonstrating you are listening to them. Use judiciously. These are called encouragers in the linguistic department. Uh-huh, uh-huh. So you could may go tell me more. Mm-hmm. With a inflection going up is a question mark. Really? You use this judicially. You mirror feelings. And next, you reflect meanings. And I'll talk about the difference between these two very shortly because they could be confused. Mirroring feelings, according to Bendix and Wright, has a focus that emphasizes, acknowledges, and validates the other person's emotions. The purpose of mirroring feelings is to show empathy by recognizing the emotional state the person is in. The method you use is rephrasing or expressions that convey how the patient feels. For example, if a patient says, and here's the verbal communication, I am really frustrated with this situation. Mirror their feelings might involve responding to that statement with these words. It sounds as if you're really frustrated right now. And they're going to go, yeah, doc, really frustrated. And you go, really frustrated. And they would then encourage them to speak again. The effect of mirroring feelings helps the patient to feel understood on a level that is going to foster trust and promote open communications. Reflecting meanings are slightly different. The focus of reflecting meanings is to clarify the intent behind what a person is saying. You're interpreting this now rather than just showing them back what you heard. The purpose is to deepen the implications of what they're expressing. And one way of doing this, if the patient says, I just don't feel as if my efforts are being appreciated at work, reflecting meanings might involve your saying, you feel you feel undervalued, as if your hard work is not being acknowledged. And they're going to go, yeah, you know exactly what I mean. The effect of this is it encourages the patient to explore their thoughts further. They're going to share more. They're going to provide more clarity, and you're going to be helped in understanding the position a lot more easier. The next bit of advice that Bendixson write in their book, The Anxious Patient in Facilitating the Story, is do not interrupt a silence. I bet that silence is uncomfortable. I just waited 10 seconds. How many of you started to wonder, what's happened with Dr. LaRose? Has he fallen off the earth? Has he gone to sleep? Has he had a stroke or some other catastrophe? Those 10 minutes might have felt very long. Or I might just have been having a senior moment. Do not interrupt a silence is the advice from Bendix and Wright. They also go on to say that if you have to say anything to break the silence, say without any intonation, without any judgment, without any condemnation, what are you thinking? Rather than, what are you thinking? Or what are you thinking? Okay, just flat, no affect. What are you thinking? Any questions? All right, the next thing we're going to talk about is barriers to listening. And I'm going to use my favorite teaching tool to help you to remember the acronym. I'm going to use noises as the acronym to learning and remembering barriers to learning. N is for obviously noise. This is self-explanatory. If there's too much background noise, no one can listen properly. Overstimulation is the O in the noises acronym. Too much information given at all at once will cause the listener to zone out, especially if you've heard this story before. I is for interruptions. These interruptions could come in several disguises: ringing of cell phones, support staff coming in for a quick signature, a call from home, a text message bleep coming through, and you can't resist the temptation to check and see what or who is sending this particular text message. S is for space. We talked about space before. Space having to do with the distance between you and the patient. Is it too much distance, or are you in their personal business and they are finding it uncomfortable? And then the E is for emotions, where either your emotions get in the way or the patient's emotions get in the way of effective listening. And this was covered in mental health. There's transference and countertransference that could occur from the patient to you or you back to the patient. And the last we've talked about is silence. Now, the next thing I want to talk about is sometimes, let me ask you this, have you ever been accused by your better half or a close friend that you're not listening? Sometimes we are actually paying attention, but we're not communicating that we are actively listening. So let me give an example. I'm counseling a group of, not a group, a couple in my last workplace. They were having marital problems. She complained that he was never listening. He says he listens, but he doesn't understand why she says he's not listening. So I gave them an exercise to practice for a week. Both of them worked. So they go home. They have to take care of kids that were with the nanny. And I said, for the first 2 or 3 days, I'm going to let the wife, let's call her Mary, start off the conversation. So Paul, let's call the husband Paul. So Paul and Mary. Paul says in order to start off the conversation, so how was your day, Mary? And Mary gets an opportunity, however long she wants, to tell Paul exactly how her day was. If it was frustrating, he gets to hear about the frustrating episodes. He is not to interrupt, to make any statement. Just listen carefully. And then he would get a turn to explain to Mary how, or tell Mary, or share with Mary how was his day. But he had to earn that right. And the way he earned that right was by paraphrasing in his own words what he thought Mary was saying. He was allowed to reflect meanings, to mirror whatever it is, to go or say nothing when there is a pause. And if he fails to accurately communicate to her that he heard what she was saying, then he had to try again. And I saw them the week later. Apparently, they never got past the first day because Peter could not, for the life of him, reflect back, paraphrase exactly what Mpo was saying. So I said, okay, let me be the referee today. I will watch and see what's going on. Okay, Mary, you get a chance. And Mary started off, and before she got into her sixth sentence, she turned and said to me, this is exactly what I'm talking. He's not listening to me. And I looked at Peter, and Peter just waits for, because I'm the referee, for permission from me for him to talk. And he says, when I said, okay, Peter, your turn to respond. He says, Doc, let me tell you what I heard Mary say. And he verbatim, exact words down to the inflection, the tone, the sometimes exasperated. He had this down to perfection. So he looks at me and says, Doc, how did I do? I said, you did well, but you did not realize what prompted Mary to say you were not listening. He says, but I just showed you. I heard everything she said. I said, yeah, you heard everything she said. But in the middle of what she was saying, you, for some reason, looked at your watch. And Mary says, that's exactly what I'm talking about. He may be going through the motions of hearing me, but he was distracted. And Peter says, I'm so sorry. I'm not too sure why I looked at my watch. I said, I know, I'm not asking for an explanation. An action followed by an explanation or an apology doesn't really wash for a lot of hurt people. Um, what is more important is that what she read or misread into your simple act of looking at your watch. She interpreted that as whatever you were thinking. It wasn't about her. You were probably considering your next appointment, or how long is this going to take? Am I going to waste another hour demonstrating that we can't communicate? Mary looked at me and says, that's exactly what was going through my mind. So, with that said, the next topic before we get into summarizing all that we've said so far is communicating active listening. My text here is it's a book called The Skilled Helper. Egan is the author, and Egan says, and he mentions 5 things, not specifically in this order, but you know me. I will take those 5 things, rearrange them such that they spell a particular word. So we're going to use the acronym ROLES. I could have used solar. I could have used something else, but roles is what I thought was most appropriate. So we're going to have to play the role of an actor, and we are going to have to demonstrate that we are actively listening by doing these things. So the R in the roles acronym stands for relax. Loosen up your shoulders, shake out your hand, let the tension go out of your legs and your feet from your neck, and just relax. The O is to have an open posture. And we talked about posture before. Your palms are going to be facing up and out. You're not going to be crossing your arms or your legs. You're going to lean slightly forward. I remember the Bible has a very neat way of expressing this. It says in Psalms 115, verse 2, 1 and 2, I love the Lord. And here is why the psalmist, and this is David writing, because he has heard my voice and my pleas for mercy. And how do I know that he has heard? Because he inclined his ear to me. Therefore, I will continue to call on him as long as I live. Wonderful piece of advice as to how does God treat us when we complain about the crap that comes in our daily lives because of our fallen nature. He inclines his ear towards us. So lean slightly forward, as in this picture. Turn your head slightly, give the patient an ear so they will see that you are listening to them. The E is maintaining eye contact that is culturally appropriate, and you know your culture best. And then the last is in the roles mnemonic is S for sit squarely. Don't sit at an angle because unconsciously, even though you might be inclining your ear towards your partner or patient, you may be inadvertently giving them the cold shoulder by presenting one shoulder more than the other. Any questions? Art, it's time for one of your breaks. When we meet back tomorrow, we will summarize all that we have covered so far in about 10 slides. Okay? So, here's the summary. The summary is titled The Power of Listening Strategies for Enhancing Patient Engagement Through Communication. This is taken from a website, The Power of Listening Enhancing Patient Communication. The link is down at the bottom. They did not specify the editor, and I would not be surprised if it might have been generated with the help of ChatGPT or Gemini or some other AI bot. So, The first of a number of slides, as I said, 10 of them, is the importance of listening. Listening is important for 5 main reasons. It enhances trust and rapport. It improves diagnostic accuracy because you're getting correct information. It increases patient satisfaction. It promotes patient compliance, and it reduces physician burnout. When you listen properly, patients feel valued and understood. It encourages them to share sensitive information. It increases adherence to medical advice. It creates a safe, judgment-free space and strengthens the doctor-patient relationships. It also improves diagnostic accuracy. How? Because symptom descriptions offer vital cues, and you need to be listening for the clues that they're dropping in the conversation. Active listening prevents misdiagnosis or delay of reaching the diagnosis. Nonverbal cues enhance understanding. Listening ensures complete assessment before decisions are made, and it improves overall clinical outcomes. In addition to that, listening improves patient satisfaction by the following. It makes the patients feel respected and heard. It reduces complaints being dismissed. The doctor didn't pay attention to me. I said I was worried about coughing up a little blood in the evenings. They didn't address that at all. It strengthens once again the patient-provider relationship by encouraging loyalty and bringing in referrals. And it improves follow-up visits. Listening promotes patient compliance by enhancing the trust in the physician. Patients feel that their concerns are being considered. Listening leads to collaboration, which results in realistic care plans that address lifestyle changes and prevents abandonment of treatment plans, another term for non-compliance. Listening reduces physician burnout by strengthening emotional connections with the patient, enhancing job satisfaction, providing practice fulfillment, reduces the stress and compassion fatigue, and encourages a patient-centered approach. In conclusion, listening is a critical skill in healthcare. Listening strengthens the doctor-patient relationships. Listening enhances diagnostic accuracy. Listening provides or improves satisfaction, not only patient satisfaction with your performance, but your own satisfaction about your performance. And as a result of that, listening reduces burnout. Here is a list of the 7 main references that I've used in the preparation of this series of lectures, just in case you're wondering where you could find additional information that would help you to become a more effective listener. If I had to recommend any one of these 7 resources, it would be number 6, Desmond Morris, The Language of the Body. The link here is for a YouTube series. It's done by It's a BBC Nature documentary written and presented by Desmond Morris. First transmitted in the United Kingdom in July 1994. I've been an avid follower of this series, produced in association with the Discovery Channel, and I must warn you, there is some nudity, there is smoking, there are obscene gestures, and there may even be foul language. So this set of YouTube videos is for the mature audience. All right. I hope you had a great time listening to this. Next week, we will be starting on the use of lab tests in order to help make the diagnosis or confirm the diagnosis or help with the screening process or with the flow and monitoring of patient management. Any questions? So here's your homework for next week. It's going to be 2 weeks for me to cover this material, which is the third chapter in Chiro Essentials Differential Diagnosis. It's about 20 pages of material. You can download the keywords, which is about 4 or 5 pages, and look at the depth and breadth of the material we are going to be looking at as part of how to use lab tests to make a diagnosis or in medicine. It may appear to be exhaustive and exhausting, but the keywords will help you focus on the important facts that I would like you to commit to memory. I have ensured that the material embedded in your questions in all of the 3 exams that you will encounter are covered in these keywords. I may, during the lecture of specific diseases, add something to it because I'm in the habit of reading about and updating my information. And if I get new information that I read the week before, I will cue you into this is brand new information by putting that information in red, and I expect you to update your keywords. Or I might say to you, Boards is not yet aware of this. This is for your own personal edification and use to enhance your patient care, but this is not going to be questioned in the boards part 2, 3, or 4, and therefore it's not going to be featured in the keyword associations. Okay, I will see you next week. Have a great weekend. Bye for now.